Adelante, adelante, adelante. Tenemos la sala abierta. Mariana, tenemos a Mariana y tenemos a Carolina Neira. Carolina, dígame si me está escuchando
The
ahí,
room is
Caro.
open. We have
Sí,
Sí,
Mariana
Pedro,
and
te escuchamos bien.
Carolina.
¿Tú nos escuchas a nosotros?
muy bien, muy bien. Así
Pero
que
we can
estamos
listen to
dándole
you well.
paso
Can
a
you
la gente
hear it?
que entra a
Yes.
la sala, pero
So
vamos a estar
we're
esperando un par
letting
de
you
minutos.
go into the room.
Solamente,
Just
Mariana,
a
¿qué
couple
tal
of
si les
minutes.
vas dando instrucciones a la
Mariana,
gente que
perhaps
van
you
escuchando,
can
sí? De cómo nos vamos a
give
comportar
instructions about
y
what
vamos a
we
seguir.
are
Pero
going to
podemos ahí
do,
empezar. Carolina, mira
and
el chat
we can
tuyo
start. Look
para
at
que
your
veas cuántos
chat,
países se
Carolina.
están
See how
incorporando
many
y
countries
podamos darle
are
la
being
bienvenida, ¿sí?
incorporated, and we can welcome them all.
Le podemos dar la bienvenida a la
We can
sesión.
welcome
Tenemos
them to
Nicaragua,
the
El
session.
Salvador,
We
que me
have
parece que
Nicaragua, El Salvador,
Paraguay, tenemos
Paraguay,
México también conectándose,
Mexico,
República
connecting,
Dominicana,
Dominican Republic,
Cuba,
Cuba,
Argentina,
Brazil,
El
Bolivia,
Salvador,
Colombia,
Nicaragua,
El Salvador, Nicaragua,
Uruguay,
Colombia, Uruguay, Chile,
Guatemala, Bolivia,
Guatemala,
Buenos
Suriname,
Aires, Argentina.
Peru, Argentina,
Bienvenidos, bienvenidos
Barbados.
todos.
Welcome
Como
you all.
saben,
As you
tenemos
know,
interpretación
Perú.
we
simultánea
have
para
simultaneous
aquellos que
interpreting to those
hablan
who
inglés o que
speak
quieren
English
escuchar la
or
interpretación
who
en
would
español.
like to
En el
listen
menú
to the
inferior pueden ver
interpretation
una
into
opción
Spanish.
de mundo y ahí
At the
pueden
bottom of your
seleccionar el
screen, you
idioma
can see
que prefieren.
um,
Como dijo el
um,
doctor Núñez y Carolina,
a globe.
los invitamos a
This
que en
is
el
the
chat
icon for
pongan
choosing
su
the language of your
destinatario, de
preference.
qué país nos acompaña,
And
todo lo que
please,
quieran
you can
compartir es bienvenido.
include in the chat
Y
anything
recordarles
you
que va a
want
haber
to share
grabación de
and
este
comment.
webinar para que los puedan
Remember,
ver y
we'll
compartir después con quien guste. Entonces, los
record
dejo con el
this
doctor
webinar
Núñez,
so
que
you
nos
can
acompaña
share that
desde
with
Chile, quienes
whoever
van a
you
ser
wish.
nuestros anfitriones este
I'll
día.
pass the floor to
Bienvenidos.
Chile,
Sí,
our
Mariana,
host
muchísimas gracias.
today. Yes,
Tenemos
thank you
alrededor de
very much,
400
Mariana.
personas en la sala,
We have
siguen
around
entrando.
400
Espero que se
people in the room.
incorporen en los
They are
próximos minutos. Este
still
va a ser un
getting in.
webinar un poco diferente, ¿no verdad?
This is going to be
Porque
a
está siendo
webinar
un
a
webinar
bit different.
híbrido.
It's
Estamos
hybrid.
en
First of
vivo
all,
en
we are
Chile
live in
y
Chile,
estamos
and
virtualmente a
we
través
are
de Hispanoamérica,
virtually.
a través
So
de
we're
los
face to face in
ODS.
Chile, and we're
Mi nombre es
virtually
Pedro Núñez,
in the
creo que,
Americas.
bueno, me
Thanks
conocen
to
mucho,
Cajo.
soy
My
el
name is
consultor
Pedro Núñez. I'm
dedicado al tema
an
de la enfermedad
advisor
cardiovascular en
devoted to
ODS
cardiovascular
y
diseases at Cajo,
además
and I'm
me
also in charge
conducir y
of
coordinar los esfuerzos de
coordinating
implementación
the
de la
implementation
iniciativa
efforts
HEARTS
of
en las
the
Américas. Hoy
Hearts
tenemos un
Initiative
programa muy
in the
interesante que va a
Americas.
comenzar
We have a very interesting
justamente,
program
voy
now.
a comenzar
Gonna
presentando a
start
mi
by
comoderatora del día de hoy. Yo tengo el
introducing my
gusto de
co-moderator
presentarle
today. I
nada
have the
menos y nada
pleasure
más
to
a la
introduce
famosa Carolina Neira,
the famous
que es la
Carolina
jefa
Neira.
Oh,
del
wow.
She's
Departamento de
the
Enfermedades
head
No
of the
Transmisibles del
non-communicable
Ministerio de
Muchas
Salud
gracias,
diseases
en
Pedro.
Chile.
department at the Ministry of Health
Caro,
in
a ver,
Chile.
hemos
Thank
tenido
you
una
very much,
semana
Pedro.
tremenda en
Caro,
Chile.
we had a
El equipo de HEARTS
tremendous
lleva una
week in
semana en Chile,
Chile.
lleva
Hearts has
desde el
been for a
domingo
week
con
in
ustedes
Chile
y
since
sé que tienen
Sunday,
un conjunto de actividades.
and there have been a number of
Comiénzame comentando a la
activities.
audiencia qué
Please
pasó
comment to the
desde el
audience
domingo en
what
Chile, por favor.
has happened since
Bueno, buenos días,
Sunday
buenas
in
tardes
Chile.
para algunos
Good
a
morning
todos.
and good afternoon
Estaba viendo que estaba
to you
Chillán
all. I see
conectado.
Chilean
Bueno,
is
hemos tenido una
connected.
semana enriquecedora donde tuvimos
We
la
have a
visita a
very
Valdivia
enriching
y aquí
week.
pueden ver las
We visited
imágenes.
Valdivia. You can
Tuvimos un
see the images
encuentro
here.
con los
We had a
promotores de salud
meeting
formados en la
with
salud
healthcare
cardiovascular, los HEARTS.
promoters. They
Hay
have
una
been
foto muy
trained in
hermosa
hearts.
donde
There's
fueron
a beautiful
reconocidos nuestros
picture.
exponentes,
Our
María Olivia, asesora
presenters
de
were
ODS. Tuvimos
thanked.
aprendizaje en
Olivia, this
terreno
is a
en
PAHO
diversos
advisor.
temas.
We had
También nos
learning in
recibió
the
la
field.
ministra de Salud
Also, the
con las
Minister of Health
autoridades.
received us
Tuvimos
together
un
with the
encuentro
authorities.
también
We had
con
a
los equipos
meeting
de atención
with
primaria.
the primary health
Tuvimos la
care
oportunidad también de
teams,
mostrarles
and we
los
also had
diagramas
the
digital
chance of showing them
a nuestros
what the
asesores
digital
y
strategy
nuestro primer
is.
taller de la
Um,
mejora de la calidad.
and also, we had a
Tuvimos
great
presentaciones
workshop
de
on
autoridades
quality
técnicos
improvement where
internacionales,
we had
acudieron tanto los
presentations by
servicios de salud
international
como la
experts,
Ceremi.
and we
Y la
had
idea es
um,
fortalecer HEARTS a nivel
healthcare
de Chile,
services
pero
and
también
the
de Latinoamérica,
CEREMI
para
that
que
we want to
nuestros
strengthen
asesores
hearts in Chile, but also in Latin America. So our advisors know about our primary care in Chile and see what we can improve in. We thank to all the experts, Daniel, Olivia, and all the experts here, Tim,
Ahí está.
Lee,
Nif.
Neil, or Nif,
Esteban, Andrés, bueno, también Rina, que no está conectada en este
Esteban,
momento.
Andrés, Rina, Libardo.
Muchísimas gracias por su expertise.
Thank you
por
very
su
much for your
experiencia, por
expertise,
entregado,
for
pero también
your
quiero,
experience, all
se
that
lleven
you
esta
have
sensación
given
de
us.
cariño, de amor,
And
y
also, I
de
want
haber
you
aprendido
to
nosotros
take
también para extender
this
a nivel de Latinoamérica.
love
Así
from
que
us
muchas
to you.
gracias por
And
eso.
thanks
Tuvimos
for
una
having
semana
extended the
enriquecedora.
message in
Aprendimos
Latin
muchísimo.
America. Very
Y
enriching
también
week. We learned a
pudimos
lot,
avanzar en lo que es Heart en las Américas.
and we were able to progress
Muy bien,
in
Caro. Yo
hearts
creo
in
que
the Americas.
excelente. Le has dado
Thank
un
you, Caro.
panorama.
You
Sabes
have
que este es el 10º taller de calidad que hacemos en las
given us
Américas.
the outlook.
Comenzamos con
This is the
Belize,
10th
¿sí?
quality
Y después nos fuimos a El
workshop in
Salvador,
the
después
Americas. We
vimos
started with
México,
Belize,
llegamos,
then El
estamos en
Salvador,
República
Mexico,
Dominicana y en
Dominican
Cuba,
Republic,
Guyana
Cuba,
y el
Guyana,
Caribe.
the
Y
Caribbean.
ahora estuvimos en Chile y estamos regresando a México a finales de
And we
este mes
went to
para el
Chile
taller de
now,
calidad
and
de
we
Heart.
will
Y
be in
yo creo que ha sido una experiencia
Mexico at the
tremendamente
end of this
enriquecedora.
month
Tenemos alrededor de
for
500 participantes
quality
y
workshop
estamos listos,
for
Alfonso,
hearts. We have
para
about 500 participants,
comenzar
and
la
we're ready
dinámica
to
de
start.
lo que va a ser este webinar de Heart en las Américas, que está dedicado a, fíjense cómo se llama, Heart
This
2.0,
webinar is Hearts
transformando los cuidados y formando el futuro.
2.0,
O sea, el problema que tenemos es
transforming
enorme.
care
No
and
se puede encarar
informing,
de la misma
training
manera
the
que lo
future.
veníamos haciendo porque tenemos
We cannot
mucho
face
chance
the
de
problems as
fracasar.
we
Así
used to
que
do
en este
because we
primer
could
módulo,
fail.
donde vamos a
So in
hablar
this
de
first
cómo
module,
integrar la
we're going to
integración
talk about how to integrate
cardiovascular,
cardiovascular
renal y
care,
metabólica a través de la
cardiovascular,
promoción
renal,
propia de la
and
salud.
metabolic
Hoy
care
tengo el
through
gusto de
primary
presentar al primer
health
ponente
care.
que es
The
súper
first
conocido en este ambiente de HAR, es uno
lecturer,
definitivamente
very
uno
well
de los
known in
mejores
this
en las Américas,
environment,
que es el profesor
of the
Donald de Petty, que es
biggest in
profesor
hearts, Dr.
distinguido
Donald
de
P. Petty.
medicina
He
en
is
la
a
Universidad
distinguished
de
professor of
Carolina del Sur.
medicine at
Es
the South
reconocido
Carolina
profesor investigador en
University,
el área
a
de
very
nutrición y
acknowledged
prevención
professor in
cardiovascular, que es
hypertension,
miembro del Team
hypertension
Heart
and
de los
prevention
consultores
of
HAR. Y de esto vamos a
cardiovascular
hablar,
diseases.
porque tenemos
And
que
he's a
entender el
member of
problema.
the Hearts
Si no
team.
entendemos el problema, no
We
podemos
must
buscar la
understand the
solución.
problem
Entonces,
because
el profesor
if
Donald
not, we
Petty nos
can't have the
trae las
solution.
bases
So
fisiopatológicas
Professor
del síndrome
Deepet will talk
cardiovascular,
about
renal
the
y metabólico. Por aquí empieza la
pathophysiological
historia, ¿no
basis
verdad,
of the
Carolina?
cardiovascular kidney metabolic.
Sí, Pedro, bueno, es muy
Yes,
importante
Pedro.
ver
It's
la
very
salud
important
cardiovascular como
to take a
integral,
look at
como una
cardiovascular
población
disease as an
probablemente tanto en Chile
integral
como en
matter.
Latinoamérica tiene
The population
multimorbilidad.
in
El
Chile and Latin
70% de la
America
población tiene
have
más de 5 patologías crónicas y el
multi-morbidity.
abordaje de esto
Here
y la
in Chile,
prevención de las
people
complicaciones es
used to
fundamental
have more than
para
five
poder mejorar la
pathologies
calidad de la
together,
atención.
and we need to improve
Muy
the
bien,
quality of our
adelante,
care.
profesor de Petty. Tiene la mesa completa
Professor
servida.
Dipet, you
El
have the
doctor
floor.
Donald Dipete, profesor
Dr.
distinguido de
Donald
medicina de la Universidad de
Dipet,
Carolina del Sur de
distinguished
Estados Unidos, le damos
professor
el
of
pase.
the
Nosotros muy
University
privilegiados
of
de
South
tenerlo
Carolina. We're
nuevamente. Él
very
es
privileged
histórico
of
en
having
lo que es
you
Heart.
now,
Así
and
que le
you're
damos
a
el paso al
historical
doctor Donald
character
Dipete.
in the heart strategy. You have the floor, doctor.
Well, thank you very much. And obviously, it's an honor to be with everybody in all the countries that were already listed this morning or this afternoon, depending on where we are. Again, it's also an honor to be together with our Chilean colleagues. It would be remiss of me if I did not say that Chile was one of the founding four countries in hearts and has led the way over a decade now with hearts. So thank you very, very much for having me. Today, I've been asked to talk about very briefly and introduce to us or expand upon the new syndrome. It came out of the American Heart Association here in the United States, the cardiovascular kidney metabolic syndrome. And we're going to do that. Let's go. We're going to first do a little bit of history and then talk about some of the basis of the CKM syndrome, and then hopefully have a brief discussion with all the other participants today. Before we really talk about specifics, though, I think it really behooves us to talk about what are we really discussing today, and what have we been discussing with hearts over the last 10 to 13 years. And there's really only one word for that, and that is change. We've been constantly talking about change and promoting change in a very general way, and then down to very specifics when we talk about each of the components of hearts and where we're going. So that is as true today as it was yesterday. So the change that we're talking about is, rather than looking at pieces, whether it's diseases or it's individuals or populations, we're going to be talking about instead of silos and breaking down silos, but bringing everybody together. And again, this isn't new for hearts. This has been a common theme forever. So what's the change? This slide here demonstrates the deaths attributable to modifiable risk factors in the Americas from 1990 to as recent as 2019 and beyond. In 1990, even then, 35 years ago, we saw that tobacco use was the #1 modifiable risk factor for death. But soon to follow was hypertension. And then on the 5th place was diabetes. And here's what's been changing right before our eyes. Now, more recently in 2019, you can see that they're #1 and #2. It's hypertension and diabetes. So it would behoove us to talk about those two together as opposed to silos. And that's the change we're going to be talking about today. Integrating disease processes as opposed to dividing them up and talking them one-on-one. This slide demonstrates that we were a little bit ahead of the curve. This was before the CKM syndrome. Many of us, led by Hearts and Dr. Dunas and the team, asked us to get together and start talking about integrating that #1 and #2 on that last table, hypertension and diabetes. Is it possible? And if it's possible, can Hearts be used as a tool? We convened a group, and out of that group discussion came this paper. So I just show it to you if you want more detail regarding what we're going to be talking about today. But it was hypertension, i.e. cardiovascular disease, and diabetes, i.e. metabolic disease, that led the way. Next slide. Thank you, Mariana, for doing that. And this is the reason why. It is not lost on us that they are completely integrated at a pathophysiologic and as a treatment and population level, as you can see here. Hyperglycemia, if you want to look at its own silo, leads to more likely microvascular disease than macrovascular disease. Nephropathy, neuropathy, and retinopathy, of course. We all know this. If you want to look at another silo, the hypertension silo, on the right side of the slide, it leads to accelerated atherosclerosis and macrovascular disease. Well, it's not lost on anybody that if you have microvascular disease with one disease state, diabetes or metabolic syndrome, and macrovascular disease with another disease state, cardiovascular disease, in this case, hypertension, the #1 risk factor for cardiovascular disease, now you have the entire system. You have both microvascular and macrovascular disease. That would be enough to start thinking about integration if it weren't even better than that. The treatment and prevention of both are the same. There are tremendous commonalities, as you can see on the slide, from healthy lifestyles and modifiable lifestyle risk factors to glycemic control to blood pressure control. That's at a macro level. But on a micro level, they're even more integrated. They share multitudes of common risk factors, as we all know, from genes to insulin resistance to physical inactivity, etc. The two disease processes, diabetes and hypertension, are interrelated. Hypertension is an insulin-resistant state. We actually fail to acknowledge that enough, I believe, independent of hyperglycemia or diabetes, which then can lead to diabetes. Diabetes, on the other hand, a microvascular state, as you will, can lead to hypertension, and the insulin resistance of diabetes can also elevate blood pressure through resistance to vasodilatory agents such as insulin itself. The pathogenesis is interlinked, as you can see, and the clinical management is strongly interlinked. All these are strong reasons why we need to break down the silos and we need to start thinking of them together independently. Well, that's hypertension and diabetes, cardiovascular disease and metabolic syndrome. And that leads us to bring into the next organ, again, from the American Heart Association, the CKM syndrome. And that's why now the three of them are postulated and strongly interlinked, as we're going to see pathophysiologically. On that first table that excuse me, that I showed you on the table, kidney disease was number 5 in the late 90s in terms of morbidity and mortality in the Americas. So we have the number 1 disease state, the number 2, and the number 5 disease state. And I will argue they're all increasing together, including obviously chronic kidney disease and end-stage kidney disease, which ultimately leads to dialysis. So this is the big definition of CKM syndrome, and these slides come from the American Heart Association. Number 1, it's a systemic disorder characterized by pathologic interactions of multiple entities, metabolic, kidney, and the cardiovascular system, which unfortunately lead to synergistic, as we're going to see, dysfunction, morbidity, mortality, and obviously adverse cardiovascular outcomes. The syndrome itself also includes individuals at risk for cardiovascular disease due to the presence of metabolic and/or kidney factors, as well as individuals with existing cardiovascular disease where the toll is already exponentially increasing. And the increased likelihood of CKM syndrome and its adverse outcomes is further influenced by unfavorable behaviors, westernization, et cetera, from policies to economics to the environment. Next slide. But this is the simplified definition, if you will. CKM syndrome is a health disorder due to connections, and that's key, connections between heart disease, kidney disease, diabetes, and of course, the metabolic component, also obesity, which clearly we all know leads to poor health outcomes. And unfortunately, these are synergistic poor health outcomes. They're not even additive. Next slide. And the title was The Pathophysiology of CKM Syndrome. And this is really the heart, if you will, the pun is intended, regarding how critical CKM syndrome is to hearts and obviously our efforts, including the efforts from during the week that you've been having in person in Chile. But notice there's something different about this diagram or figure, if you will. The heart isn't in the middle. The kidney isn't in the middle. The obesity, the metabolism, metabolic syndrome's not in the middle. What's in the middle? What's in the middle is inflammation, oxidative stress, insulin resistance, and vascular dysfunction, common to all 3 of these entities. That is key, I believe, to the word change that we started with. We have to change our thinking from this cardiovascular disease or this endocrinologic disease or this renal disease. We have to think about the commonality to all of them. And as we all know, inflammation is rising to the top. Unfortunately, we've seen that as recently as the COVID pandemic, where inflammation itself, independent of the infectious disease process, was crucial in promoting tremendously dark days with morbidity, mortality throughout the world, not only in our individual countries. So but the disease states itself, starting with adipose tissue, yellow adipose tissue, if you will, a cytokine factory. Of course, hypertension, dyslipidemia, and metabolic syndrome, including diabetes, then markedly contribute. The kidney is not without fault. The kidney is both the damaged organ, but also the damaging organ, as well, as you can see by this diagram. And then clearly, the cardiovascular disease processes of atherosclerosis, both microvascular and macrovascular, and cardiovascular disease from angina to myocardial infarction to heart failure, which we know the prevalence is extraordinarily increasing worldwide, including in my country. Next slide. So let's understand some of the underlying science behind it. CKM syndrome results in excess morbidity and mortality. And I've already said the S word, synergistic, multiple times, beyond the sum of its parts. It's not additive. The metabolic risk factors cause end organ damage in the heart, kidneys, and vasculature, which themselves then lead to further damage. The mechanisms of end organ damage are hemodynamic, metabolic, but more importantly, I believe for us to start breaking down silos and increasing our thinking and change is the inflammatory process, the cytokine storm, and obviously then necrosis and fibrosis. By then, it's too late. Next slide. Well, that would be okay if the disease state wasn't that prevalent. This is new data that just came out last year from Dr. Agarwal and his team, looking at our population-based data bank called the NHAIDS data. And what Dr. Agarwal and colleagues did was take the NHAIDS database, the last database, which was over the 10 years of 2011 to 2022, and plugged them in to the CKM syndrome. How prevalent is the CKM syndrome using our own data that was already there? Instead of silos now, putting that data together and coming out with a common prevalence rates, if you will. Also, what I didn't show you is the CKM syndrome has been divided into 4 stages, with 0 being the 5th one. So stage 0 means there's no risk factors for CKM syndrome. In my country, that's the vast minority of individuals, as you can see, 10%. Stage 1, which is excess or dysfunctional adiposity. Remember the adipocyte, the yellow adipocyte, the cytokine storm factory, 26%. Stage 2 now progressing to metabolic risk factors or already the presence of CKD, 50%. Stage 3, getting more and more ominous, subclinical cardiovascular disease, 5%. And stage 4, obviously where we do not want to be, clinical cardiovascular disease within the CKM syndrome, plus or minus kidney failure, is 10%. So if you add all of those up from stage 1 to stage 4, the prevalence in the United States in adults is 90%, almost everyone. There are subsets, though, that are more affected. Advanced stages of CKM syndrome are greater as we age, of course, in men versus women. And importantly, there's ethnic and racial disparities. Our Black population compared to our white population, our CKM syndrome stages 1 through 4 is higher prevalence than our white population. This has implications globally, of course. Next slide. So let's conclude and put together some closing thoughts regarding the cardiovascular, kidney, and metabolic syndrome, and why did we allocate this time today for this webinar and this series? Well, number 1, cardiovascular, and I put in parentheses because I'm a little biased, hypertension, which is the primary risk factor, kidney disease, and then metabolic, which in parentheses, diabetes syndrome is. Composed of major independent and interdependent cardiovascular risk factors and pathophysiologic processes centering around inflammation, oxidative stress, etc. Unfortunately, it's markedly increasing globally. That data from my country of 90% prevalence of stages 1 through 4, I don't believe that's any different than anywhere else once we start looking at our own countrywide or even region-wide data banks and plugging in the CKM syndrome definitions. Unfortunately, it's still poorly diagnosed, treated, and controlled, even in my country. So that behooves us then to think about change. Think about how we change as individuals, but how do we change organizations? And how do we change regions and the thinking process? The importance of the recently described cardiovascular kidney metabolic syndrome, it is directly addressed and managed by the heart's technical package, pillars, and clinical pathway, as I hope we're going to expand upon and we're all going to see and recognize. Last slide. I thank you all for having me. I thank you all from South Carolina, here on the coast, the East Coast of the United States. Please welcome anybody and everybody to visit. And again, thank you for having me. And I look forward to a very, very brisk conversation and further data regarding where we are, but more importantly, where do we want to go?
Bueno, excelente, profesor Dipetti, como siempre. Usted ha
Excellent,
puesto
professor.
los puntos sobre las IES.
You have marked
Yo
the
creo que hay un
dots,
mensaje que
as we
tenemos que
say.
llevarnos aquí
I
de
think
este
there's a
problema va a crecer
message
y va a seguir
we
creciendo
need
y
to
tenemos
pass.
que
This
estar
problem is
preparados
growing and will
para
continue
abordarlo
growing,
de una
and we
manera
have to be prepared
efectiva.
to
Por
tackle
eso,
with it effectively.
yo tengo mi segundo,
This is
antes de
why,
llegar a las rondas de preguntas y
before
respuestas, voy a
going
aprovechar y
to
voy a
the
presentar entonces
Q&A
a
round,
otro profesor
I'm
distinguido,
going to
¿sí? Que es
introduce
el profesor
another distinguished
José Daniel
professor,
Piñeiro.
Professor José
Profesor
Daniel
Piñeiro
Piñeiro.
es profesor de la
Professor
Universidad de
Piñeiro
Buenos
is
Aires, fue
professor
presidente
of the
pasado
Buenos
del
Aires
mismo
University.
presidente de la
He
misma
was past
federación,
president of the
¿sí?
World Health
Y además
Federation,
un profesor
and
ilustre.
he's
Y mira, mira
a
Daniel,
very well-known
Don nos ha presentado
professor.
la
Look,
fisiopatología
Dan, Don
del
has
síndrome
presented the physiopathology
cardiorenal-metabólico, ¿sí?
of the
Pero ¿cómo hacemos
CKM
que esto
syndrome.
funcione? O sea,
But
imagínate la gente
how
que está
can
trabajando en la
we
atención primaria de salud,
work
¿sí?
with
Imagínate
people
que no
having this
solamente la atención
problem?
primaria de salud, porque
Let's
fíjate,
think
yo pienso
about
a veces los
primary
cardiólogos
health
la tienen más
care,
fácil, porque
and
tú
not
sabes que
only
el
primary
cardiólogo
health
llega,
care.
ya viene con el triage. ¿Cuál es gente con
Cardiologists
un problema del corazón?
already know
¿Verdad? Lo
people
cual no
come
quiere
to
decir
them
que no
with
haya
a
que
heart
enterarse
problem,
sobre el que está
but
sentado
they
ahí
have
y
to
viene con el
integrate
contexto del
things,
médico
right?
familiar. Que se le
But
llega a cualquier tipo
family
de paciente y tiene que
doctors
estar
for
listo.
primary
Entonces,
health
¿cómo se lo
care
hacemos? ¿Cómo le hacemos
centers have to
la
be
vida fácil?
ready
Carlos,
to help
que
these
tú,
people.
Daniel Piñeiro, nos va a presentar
So
entonces
Daniel Piñeiro will talk
guías,
about guides,
escucha,
protocols,
guías de práctica clínica
and the clinical path.
protocolos
Make it
vía
simple
clínica.
to make
Y
it
dice,
possible.
hacerlo simple para hacerlo posible. Tratando de distinguir qué es lo
The
diferente, que
idea
no es lo
is
mismo.
to
¿Sí? Que no es lo
understand
mismo.
what
Adelanto
is
eso. Adelante,
different.
profesor Piñeiro.
Professor
Bueno,
Piñeiro,
gracias,
you have the
Pedro.
floor.
¿Me están
Thank you very
escuchando
much,
bien?
Muy
Pedro.
bien.
Can you hear me?
Bueno,
Yes.
entonces muchas
Yes,
gracias
go
por la
ahead.
presentación.
Thank you very much for this
Le mando
presentation.
un fuerte abrazo desde
I
acá, desde Buenos Aires, Argentina.
embrace you all from here, from
Vamos a
Buenos
empezar
Aires, Argentina.
un poquito con este tema.
We're going to get
A ver si
started
puedo pasar yo los
with this
slides o los
topic.
tienen que pasar ustedes.
Let me know if I can pass them. I can pass my slides.
Yo no puedo pasarlos.
No, I
So,
can't.
next. Bueno, yo no tengo conflicto de intereses para esta
I have no
presentación.
conflict of
Les quiero
interest
contar
with
que en
this
el año
presentation. I want to tell you
1992, a ver si
that
puedo pasarlo yo, ahí está.
in
En el año 1992
1992,
aparece este concepto de medicina basada en la
this
evidencia,
evidenced-based medicine
como
comes up.
nueva aproximación para la enseñanza
This
de la
was a new
práctica de la
approach
medicina.
to teaching the
Realmente
practice of
la
medicine.
medicina basada en la evidencia
And
ha hecho un gran
evidence-based
cambio
medicine
en
has
nuestra
made
manera de
great
pensar
changes in
la
our
medicina.
way of
Yo
thinking about
recuerdo
medicine.
cuando hacía mi residencia hace
I
más de
remember
50
when I
años,
was a
uno
resident
dependía de la
more than
experiencia del
50 years
maestro,
ago, we
de si
depended
esto
on the
andaba bien, y ahora
uh,
aparece esta nueva
teachers
herramienta que
or
es la
professors'
medicina basada en la
experience.
evidencia.
But now we
Y
have this evidence-based
esta medicina basada en la
this
evidencia se basa en
evidence-based
la
medicine
mejor evidencia clínica
is
disponible,
founded on the
la
best
experiencia
clinical
clínica
evidence
individual
available,
y los
the
valores
individual clinical
expectativas del paciente.
expertise, and the
Y yo
patient's values
estoy
and expectations.
convencido
And
que
I'm
esta
convinced
herramienta ha sido
that this tool
significativa porque
has
cambió
been
nuestro paradigma
significant
de
because
cómo
it
entendemos la
changed
medicina.
our paradigm
Y,
about how
y
to
las,
understand
y
medicine.
la
And
herramienta más importante
the
en la
most
medicina basada
important
en la
tool
evidencia ha sido la
in this
guía de práctica
evidence-based
clínica.
medicine
Una cosa
have been the
extraordinaria
evidence-based
que
guidelines.
ya
An
se
extraordinary
genera
thing
por los años
that is
80
generated
y
in the
todos nosotros
80s,
estamos sometidos hoy
and
a las
we are
guías
all
de
submitted
práctica clínica.
to these
Es decir, no desconocemos
evidence-based
que esta es una
guidelines. These
herramienta
are clinical
fundamental.
practice guidelines, and this is a fundamental tool.
Sin embargo, fíjense que ya en esta publicación el año 2014.
However,
Estos autores hablan de
publication
la
of
tercera basada en evidencia,
2014
un movimiento en
shows
crisis.
that it
Es
might
decir, que
be a
podemos ver
movement in
que
crisis.
ya
The
para
title
los
of this
años
article or this paper is
de este
Evidence-Based
siglo,
Medicine, a
empieza a
Movement in
haber una
Crisis. At the
dificultad
beginning of this
con la
century,
medicina basada en la
we
evidencia.
start
Y les
having
quiero comentar cuál es
difficulties
esta
with this kind of
dificultad.
medicine. And I'd like to comment what difficulty this is.
Yo lo que tengo dificultad es pasar la diapositiva.
I don't know how to pass my slides. Those are my
La primera
difficulties.
dificultad es que las
Okay,
guías
the
de
first
práctica
difficulty
clínica
is
son
that
guías
these
académicas
guidelines
de
are
alto
academic
nivel
guidelines,
académico,
a
pero
very high academic level,
tenemos que tratar de
but
implementar estas
we have
guías
to
en la
try to
práctica.
implement
Es
these
decir,
guides in
pasar de
practice.
la evidencia a la
That is
acción.
going from
Y
evidence
esta
to
ciencia de la
action.
implementación es la
And
que
this
mayor dificultad
implementation
nos ha traído.
science is what brings the most difficulties.
Y decía Pedro, y yo estoy convencido,
And Pedro was
que
saying,
el
and I'm
problema
convinced
de
of this, that the
de la enfermedad
problem
cardiovascular,
of
del
cardiovascular
cáncer, de la
disease, of
diabetes,
cancer,
el
of
problema a nivel de la
diabetes,
salud pública, no lo
the
vamos a
problem in
resolver
public health
nosotros
is
los
not going to
especialistas,
be
los
solved by
cardiólogos, los
us, by
cardiólogos,
specialists,
menos
by
los
cardiologists,
hipertensólogos o
nephrologists,
los especialistas en
or
insuficiencia
specialists
cardíaca.
in hypertension
El
or
gran,
heart insufficiency.
actor principal de esto es el médico de
The
atención
main
primaria,
person
que tiene que
here
dar
is the
cuidados
primary
preventivos,
healthcare doctor
hacer diagnóstico y
that looks at
tratamiento, manejar las
preventive
enfermedades
care, that
crónicas,
manages
educar
chronic
al paciente y
diseases,
coordinar sus
that
controles.
educates the
Entonces, este es el rol que
patient and
tiene el médico de
coordinates
atención primaria,
his or her
que ahora
care.
se
So
enfrenta
this is
con
the
esta
primary
multitud
care
de guías.
physician's role.
Entonces,
And now
vamos
he
a
or
ver
she
que entre
has this
2020
multitude
y
of guides.
2025,
And
en
in
PubMed,
2020,
nada más que
2025,
con
in
hipertensión
PetMed,
arterial,
just with
existen todas estas guías.
blood hypertension, we have all of
65
these guides,
guías. ¿Quién puede leer
65 guides.
65
Who can
guías
read
que
65 guides
corresponden?
that
Y acá les voy a mostrar los
correspond?
más importantes.
And here I'm going to show
La
you the
de
main ones,
la
the
de la
most
Organización
important
Mundial de la
ones.
Salud, de la Ciudad
The one
Europea,
from the
la Sociedad Europea de
WHO,
Hipertensión,
the other one
Latinoamérica,
from
Renal.
the Hypertension,
Esta es la
European
cantidad de
Hypertension
páginas que tiene cada
Society,
uno de
etc.
ellos.
And you have a lot of
Es decir, que tenemos hasta
pages in
escrito
each guide.
280 páginas para manejar
So we
solo
have
la
280
hipertensión arterial.
pages
Es
just to
decir,
manage
de 9 a
blood
14
hypertension.
horas
So
leyendo
9 to
estas
14
guías para
hours
tratar a un paciente hipertenso.
reading these guides
Que
to
además
treat
tienen contradicciones entre ellas. Entonces voy a tener
hypertense patient.
dificultad. Pero bueno,
So, and
lo que
also
pasa
they
es que
have
yo vivo acá en la
contradictions. So it's going to
Argentina,
be
entonces
difficult
yo
to
también tengo que leer el
understand.
Consenso Argentino de Hipertensión
In
Arterial
Argentina,
y también apareció un scientific
there's
study,
also the
American College of Medical
arterial
Health,
hypertension
y esto me
concept.
agrega a
And
mí
there's also
81
another
páginas
paper
de
from the American Heart
sociedad,
Association,
más
and
mi
this
libro
adds
del American College of Medical Health.
81 pages.
Es
Well,
decir,
so I have
pasaría
81
2
pages from
años
the
por
American Heart
leer,
Association, 80 pages
3 o
from the
4 horas
Argentinian
más
Heart
diarias.
Association. So 3
Mi
or 4
pregunta
additional
es,
hours of reading. So
¿puede
my
un
question is,
médico de atención
can a
primaria
doctor, can a
tomarse
primary
20 horas
healthcare doctor
o 24
take
horas, leyendo
20
los
hours
guías
or
para
24
tratar
hours
un,
to read
una
guides
enfermedad que es la
to
hipertensión, porque
treat
después tiene que hacer lo mismo con la insuficiencia renal, con el cáncer
a disease like hypertension, and
uterino,
then they
con las
have to do the
vacunas,
same with
etcétera, etcétera? Esto es
vaccination,
inviable,
cervical cancer,
inviable.
etc. No, it's
Entonces,
impossible.
es muy importante
It's not viable.
la
And so it is very important
generación de estas vías de tratamiento
to
clínico
generate these
desarrollado por la
clinical
iniciativa HEARTS. Y
guides,
obviamente este es invalorable el aporte de
these clinical
Pedro y
treatment
Andrés
guides.
en
And
este
so
aspecto.
the
Fíjense,
Pedro's and Andres's
ahora estamos
contributions are essential in this sense.
de una vía de tratamiento clínico, una sola
So here we
criteria,
have
una
a
sola
clinical
criteria,
pathway
para que
that
usted,
has
que es el
one
médico de atención
single
primaria,
sheet
pueda
so
manejar
that primary healthcare
eficientemente la
doctors
hipertensión arterial.
can
¿Y qué consiste
efficiently manage arterial hypertension. And
esta
what is
vía
this
clínica?
pathway about?
Bueno, primero, ¿cómo
Okay, so
tomar
first, how
bien la presión
to
arterial? Desde el equipamiento
measure
automatizado
blood tension appropriately. So 8 variables to accurately measure blood pressure. There's very often a problem in diagnosis when it comes to accurate blood pressure measurement. This is point A. Point B, cardiovascular risk. PAHO and the HEARTS initiative have developed this tool that is available for free in all of the mobile phones. And this is also available for each region. And this is very important. We cannot lose 1 minute in treating the patient. And also, here we have the cardiovascular risk calculator. And last but not least, we have the treatment, the treatment protocol. This treatment protocol is not a recipe that comes from Washington. It's a co-creation of the HEARTS initiative and each group in its country. Look, it's very interesting.
Fíjense qué interesante. La parte
Look, it's very
superior,
interesting.
ustedes tienen
At the top,
objetivos cardiovasculares
you have
de
cardiovascular
acuerdo
objectives
al riesgo que tiene el paciente.
according
Y
to
ya
the risk that the patient has. And there,
medicaciones como la
you have
aspirina,
medication
como
like
las estatinas, es
aspirin,
decir, no
like
se queda solo el
statin.
tratamiento
So
de la presión arterial,
it's not
sino que se
only
expande
the
al
blood pressure
tratamiento
treatment, it
con riesgo
expands
cardiovascular.
to
En la parte
cardiovascular
media
risk
están
treatment. In the middle
las
part,
drogas, termisertana
you have
melamina, después
the
aumento
drugs,
de las drogas, el
the
agregado
increase of drugs,
hidroxapropexida y finalmente
and finally,
los tres drogas. Esto es una co-creación. ¿Qué quiero decir?
the drugs.
Si en
This
su
is a
país no hay
co-creation. What do I
termisartán,
mean?
usted ahí puede poner losartán, puede
If
poner
in your country
valsartán.
you don't
Si
have
no hay en
losartan, you
Amsterdam ni
can
Filipinas,
use another drug.
hay
If
una
you don't have
publicación
Martaban, you
muy
can use
interesante
another
en la
drug.
Filipinas
And
que
there's a
habla
very
de pongamos
interesting
en este esquema
publication that says,
lo que
let's put in the
nosotros
scheme
disponemos, lo que
what we
nuestro medio
have,
dispone.
what
En la
our
parte
medium
inferior,
has.
fíjense
And in the
que hablan
at the
de las
bottom,
vacunaciones.
they talk
Es
about
decir,
vaccination.
la parte lateral es
The
todo lo que
lateral
sea
parts,
tratamiento no farmacológico.
everything
Lo
that's
que
a
quiero decir,
non-pharmacological
para el
treatment.
médico práctico,
So for the
ese que está sentado en
doctor,
el consultorio que decía Pedro,
the
esta
one that's sitting at
carilla es
the
de un valor
office, as Pedro said,
inestimable.
this
Por
sheet
eso que
is
nosotros
very valuable.
publicamos hace poco tiempo junto con
This is
Pedro,
why
con
we
Donald,
publish with
Andrés,
Pedro, with Donald,
con
with Andres,
colegas, esta breve comunicación
and with other colleagues. This
es
brief communication,
traduciendo las guías y los protocolos,
which is
las
translating
guías de cuidado
guides,
clínico
protocols,
para un
and clinical
programa de
pathways
implementación efectiva.
for an effective
Estamos
implementation
hablando de la
program.
implementación. No
We're
estamos
talking about
hablando
implementation. We're not
ni
talking
de la
about
investigación básica, ni
basic
siquiera de
research.
investigación
We're not
clínica.
talking about
Sí
clinical
estamos
research.
hablando de la
We
ciencia de
are talking
implementación.
about the
Y
science of
voy a ser
implementation.
muy breve para
And to
esto
be
y los
very
invito a que
brief with this, and I
consulten
invite you to
este trabajo.
look at this
Partimos de la
work.
definición de lo que son las guías, los
We started
protocolos de
with a definition
tratamiento y
of
las vías clínicas.
guides,
No
treatment
es que
protocols,
desconocemos
and
el valor de
clinical
las guías,
pathways.
pero lo que
It's not that
queremos
we're
es
ignoring
facilitarle
the
la vida,
guides
porque
value,
las
but
guías
we
muy bien
want to
hechas, que no
make
las lea nadie,
your life
es
easier. Because
absolutamente
having great
contraproducente.
guides that nobody
Entonces,
reads
en este
is
cuadro
useless.
pasamos
And so in this,
de la definición, los objetivos que tiene, que son diferentes de los objetivos de un material académico, como es la guía,
so the
a un
objectives are
material de
different
implementación, como es la
when
vía
you
de
have
implementación
academic
para
material
el
and
terreno.
implementation material.
El alcance que tiene, las funciones que tiene,
So the
y
reach, the function,
los desafíos de implementación.
and the implementation challenges.
Los roles y las
Format,
responsabilidades, que esto es muy importante. ¿Quién
the
va a
roles
desarrollar
and responsibilities. This is very important.
los desarrollan los expertos a un nivel
The guides were developed by the experts
Las vías
at a national and international level, but the pathways
es una
But the clinical application pathways are co-creation.
Bueno, el desarrollo, aprobación, implementación.
So the development, approval, implementation, and the HEARTS application. We are truly convinced that digital medicine and now artificial intelligence have to be transformed in a useful tool to improve this implementation. These clinical pathways are an essential tool that we provide to the primary healthcare doctor so that he can avoid that guide mare magnum that the specialists manage. And so artificial intelligence is probably going to have a role. It's interesting to think about how we can increase this tool ethically to diminish differences and inequalities and not increase them. And as Albert Einstein said, everything should be made as simple as possible, but not simpler. We're not simplistic, but we want to provide the practical doctor with a practical, effective, and efficient tool. And with this, dear Pedro, thank you for being with us today. And I send you a big hug from Argentina. Thank you very much, Danielle, a professor of your level, president of the Federation, with the experience that you have gathered in your life and with your university experience. These concepts, well, everyone seems to manage these concepts, but actually there's a huge level of confusion. So now, Carolina, you want to comment on why Aaron's clinical pathway in Chile was a very important contribution to improving the quality of care in your country. Thank you, Pedro. The clinical pathway had a lot of, well, there were schemes that were very complex, and primary healthcare doctors, well, the clinical practice varied from one doctor to another one in the same healthcare center. The protocol is a pharmacological protocol, but the clinical pathway simplifies the components, and it also makes the health participate in each of the components. And there's standardized. And so the primary healthcare doctors can use something that's proved, and 80% of people have hypertension. This is the main risk factor for Chile, probably Latin America and the world. This avoids ischemic and cerebral diseases. And so we have all of the clinical pathway components, and this supports the doctors, but also the team, because it has components that the whole team read.
Muy bien, muy bien, muy bien, muy bien, Carolina. Por eso ahora en esta sesión.
Thank you, Carolina. Very well.
Andrés Rosende, sí, que ha tenido a su cargo conducir este primer esfuerzo hacia la vía clínica de HEARTS, y ahora hacia HEARTS 2.0, nos está diciendo, si seguimos por la vía clínica de HEARTS, adiós a la fragmentación y mayor prioridad
the clinical guide. We have more fragmentation and less quality in primary healthcare. Please go ahead, and Andres. Andres, welcome. He is a cardiologist. He is our consultant, our clinical consultant for hearts in the Americas, and he is responsible for the clinical technical packages concerning hearts. Thank you, Pedro. Thank you, Danielle and Dawn. It's always a pleasure to share these conversations and these debates with you. The HEARTS clinical pathway is our main implementation tool. As Daniel said in his intervention, this has allowed to take the highest scientific standards to primary health care in a way that's simple but not simplistic. It's robust, it's practical. And the result for the moment is pretty successful because for the moment, 28 countries in the Americas have adopted this and have adapted the clinical pathway model for the management of arterial hypertension and the management of cardiovascular risk, as Daniel was saying in his presentation. The clinical pathway also contains other conditions with, like, for example, statins, aspirins, vaccination schemes for adult population, because we know that this is quite limited in the region. Next, please. Why do we use a clinical pathway when there is a lot of evidence and so many clinical guides? And well, the answer is here. Clinical pathways appeared, as Daniel was saying, as a solution regarding the great amount of available scientific evidence that with time they started becoming part of the problem due to their extension and because the countries and scientific societies are very prolific when it comes to producing these kinds of documents. And so we cannot wait, we cannot respond to this epidemic thinking that health teams will read 200 pages guides. And so, to strengthen what Daniel was saying, and this article that we published a couple of months ago, we can find a nutshell in this slide that we see here. The scope is the scientific academic scope. Clinical guides are necessary. They cannot be used by health services, primary healthcare services. Standardized protocols are implementation tools. Yes, they are simple, they are practical, and they are based on evidence. But what is the problem? They still have a fragmented approach, a vertical approach. And the professor was saying that we need a horizontal and a cross-sector vision. And here's where we have the HEARTS clinical pathway. It includes recommendations based on evidence that come from different guides and from different areas in the same instrument that provides comprehensive look at the issue. Let's go to the next one, please. Why do we need to go to HEARTS 2.0 if we have already reached this landmark, which is the clinical pathway adoption? This is a comprehensive instrument, and it tries to break fragmentation and the vertical approach, but it has still a lot of space for improvement to include multi-morbidity. There are epidemiological nexus, physiopathological nexus, and the integration is necessary. And so HEARTS 2.0 was born as a collaborative international project that gathers the main specialists in cardiovascular specialties in the world and the people that conduct HEARTS in the countries with the aim of improving the management of multi-morbidity with a focus in the cardiovascular kidney metabolic syndrome to promote a more coordinated action. The HEARTS 2.0 methodology is finally a three-phase project. The first phase is a global consultation on priorities of interventions to integrate the new clinical hearts guide, and then the countries were asked about the availability of these interventions, if they could be implemented, and what were the obstacles or barriers to implementation. And finally, we're in phase 3 of the final agreement based on evidence. And now we're going to quickly explain what this is about. This is the phase 1 publication. I like to put it here because of the authors list, fundamentally, because we have people from the Ministries of Health, and we are working together with the maximum experts in terms of hypertension, cardiovascular disease, and epidemiology in the 5 continents, and being part of an international collaboration that is committed with creating an answer to the main global health problem is very inspiring. I'm not going to go into detail intervention by intervention. I'm just going to put here to illustrate what we have in terms of diagnosis, what do we have in terms of cardiovascular management, in terms of non-pharmacological treatment, pharmacological treatment, a lot of interventions, many of which are very new, and they will need to be included in the new clinical pathway. But there are others that the panel wanted to strengthen because these recommendations are present in the current clinical pathway or messages that needed an update according to the most recent evidence. The most important thing in the process is that no recommendation, including the current medical pathway, was recommended to be eliminated. And this shows the methodological robustness of this evidence-based instrument, and this explains the great adoption it has had in the countries that implement HEARTS, well beyond PAHO's insistence. And so thank you for supporting us in that effort. Phase 2 was based on a consultation. We like to do things in a very participative way. So we were balanced between the academia, thematic experts, implementers in countries. We have done a consultation, and now the article is being reviewed to be published to 26 countries, 26 ministries of health. We asked them that out of these 45 candidate interventions identified in phase 1, current level of availability, how do you see the possibility of implementing this, the time to transform this into a practice standard, and the identification of the main barriers? I don't want them to look at this graph in detail, but the color code will allow you to identify that the first column has the degree of availability of these interventions. Then we have a red stain, which is pharmacological therapies. Here's where you have the greatest gaps. But most of the countries have said that this is feasible in terms of implementation, and the barriers that are present could be overcome. Here we have cost barriers for pharmacological interventions, as well as other interventions like regulatory barriers or cultural barriers, for example, concerning team-based work. And phase 3, which we are conducting, finalizing at the end of this month. Well, we have worked with the Science and Impact Unit from PAHO, and we have done a classification of these candidate interventions that experts have agreed upon during phase 1. So they can be considered as a practice standard, and they didn't need a systematic review, a systematic evidence review. And those that did need the exhaustive review using a method validated like the grade methodology, and then we we created our evidence synthesis document to assess appropriately decision making. And we have done this seeking synthesis of high quality methodological guides. And here we have the concepts that Danielle was commenting on. We are not replacing clinical practice guides by the clinical pathway. We're saying that clinical guides are a fundamental tool to inform clinical pathways that are effective when it comes to implementing the best evidence. And so to conclude, I just wanted to strengthen the methodological robustness of this process. Several people present here belong to universities, scientific societies, and ministries of health, and they will be very familiar with the development of a clinical guide. And so what they do is to establish the objectives using mainly, and I think that this is the main implementation problem. They are based on a vertical and comprehensive approach. The research questions are defined. Then there's a systematic review of evidence, meta-analysis that is synthesized, and the panel that participates uses a rigorous methodology to develop recommendations. What did we do in Hearts 2.0? We turned this around. We said, let's ask those who know most about this topic because they are global experts or because they implement arterial hypertension programs where the priorities are with a public health approach. So not a vertical approach, but an integrative horizontal approach. And once that we had these interventions with PAHO, we translated it into peak questions. So what question is behind this answer? And once we had the question, we started looking for the evidence. And before accessing primary sources, we took advantage of the efforts by the clinical guide groups. So we had interventions that go from hypertension management to kidney disease prevention, management of diabetes, vaccines, etc., and many other interventions. Finally, the conclusion of this process and what we hope to obtain in the next steps is we are convinced that we are part of a global movement that seeks to change the paradigm, but always using the instruments provided by science and ensuring that there is a consistency with a focus on implementation between a great guide availability that are often very rigorous, but that are fragmented in their approach. Given the very high prevalence of hypertension and type 2 diabetes and the consequences explained by Don in his presentation, we need to have effective implementation tools that can create responses, and then clinical guides appear as a possibility. Sorry, clinical pathways are a possibility to solve this problem. Finally, the heart's pathway development will, we hope, optimize the resources, reduce care fragmentation, and will improve the quality of healthcare services, and also will improve equity or equality. Once we have developed this tool and once the countries have appropriated this tool, it will certainly push the limits of primary health care to provide a more effective care regarding the main mortality or death cause at a global level. Excellent. Oops. I have a little problem here.
Sí, claro. Ok, bueno, discúlpame Andrés, tremendo
Sorry,
trío,
Andres.
¿no? ¿Dónde
Quite a
viene por
trio.
fisiopatología?
Don Petit for
Del
physiopathology.
síndrome cardio-renal-metabólico vino
Then for
profesor David
cardiovascular
Piñero a decirnos, mira,
metabolic
dame
syndrome, we
esto
had
fácil,
Professor
no lo
David
vamos a
Pinheiro.
entender, ¿sí?
Let's make this easy. And then we had Andrés Rosen. The main message, Andrés, is if you want a pathway, because now what's happening, and this calls the attention of Don, Danielle, and Andre. Now we have the new ECC guide for hypertension, and the natural trend. Well, there's a tsunami of people that want to do pathways, and in essence, they repeat what the guides that are present say, like the American guide, and it takes a lot of time to do this. And what we are saying is simplify your life, go straight to the point. But if you use this clinical pathway, use it when you're going to design. And I believe that this is a very important topic. As Andrea and Danielle were saying, each country defines this based on their resources, based on their culture, based on their preferences. So they choose their medicine, their drugs. And it also depends to the access that they have. You can want a certain medicine, but if you don't have access to the medicine, well, not useful. So this is a very important topic. Thank you very much, the panelists. And now a big round of applause for the three of them because these are very clear concepts. People in the room, people are there in the room. The Chileans are active, and we also have a lot of people through the chat. They are providing comments. Most of them are good. Some are a little bit critical, but that's good. So some people are concerned about standardization, and this goes against the humanization of care. The heart's pathway, as any instrument of this kind, is not saying that we should not take into account clinical judgment. No, each patient has individual features. What we cannot continue doing is guessing what each patient needs. If we don't change our approach, we will not be able to have more impact. And so I congratulate the panel. And now let's go to the second section. But first, a video. Go ahead, Mariana.
In the Americas, as around the world, cardiovascular diseases are the leading cause of death. But so many of these lives could be saved with better control of hypertension. If we could raise population control from 36 to 50%, we would prevent nearly 440,000 deaths and almost 3 million cardiovascular events. From the global vision of the World Health Organization came HEARTS. Led by Ministries of Health, HEARTS in the Americas has evolved into a strategy for quality improvement. Today, 33 countries are committed. More than 9,900 health centers are implementing HEARTS, reaching 42 million adults. We are transforming primary health care with the HEARTS clinical pathway, promoting team-based care and the use of data for continuous cycles of improvement. In 2025, over 6.3 million adults are receiving treatment, and more than half already have their blood pressure under control. But our story is still being written. Over 200 million adults in the Americas live with hypertension. And our goal is clear, that everyone has access to better care. This is HEARTS in the Americas.
Bien, muchísimas gracias Mariana por esta producción y por recordarnos el alcance de HEARTS en las Américas. Y estamos listos para el segundo panel. Entonces, Carolina, ¿qué nos trae el segundo panel?
Pedro, tenemos una pequeña dificultad.
We
Vamos a
have
ver si
some difficulty, Pedro.
ya no. Ya,
Let's see.
perfecto.
Okay.
Gracias,
Well,
Pedro.
very well, Pedro. Beautiful video. We were commenting with Esteban here. It's their representative. Before starting with the second part concerning humanization of care, the main humanization of care is providing quality care. We
Calidad
start with
y
that.
centrado en la persona. Tenemos que
Quality
dar la
and
mejor evidencia disponible a la
person-centered
persona
care.
y hagamos
We have
lo
to
que
work
estamos
with the
destinados a
best
hacer
evidence
en relación
possible
a la
and
entrega
do
de
what
calidad
we need to do concerning
en un acceso
providing
seguro y oportuno.
quality
Bueno,
in
nuestra segunda
safe and
parte
timely
que
access.
se llama HEARTS como
Concerning the second
estrategia
part,
de mejora de
this is
calidad
called
para avanzar
HEARTS
en
as a
los niveles de
strategy
HEART
of quality
correcto.
improvement
Y aquí
to
tengo el honor de presentar a una
progress in
panelista.
HEARTS
A mi derecha
2.0.
se encuentra Esteban Londoño, que es
We have
asesor
Esteban
del
Londoño,
PS de
who
HEART
is
en las Américas.
PAHO advisor
A mi
for Hearts in the
izquierda se
Americas.
encuentra
On
la
my
doctora
left, we
médica
have
familiar Marcela
Dr.
Rivera del Ministerio de
a
Salud,
family doctor,
referente al Servicio
Marcela
Vascular de la División de Atención
Rivera,
Primaria.
who is
Online
in charge
está
of primary health
Vania
care
Batista,
of
de la representante de la
the
Organización
Ministry of
Mundial de
Health
Salud en
in
República
Chile.
Dominicana,
And
y
then we have Vania
un
Batista,
ya
representative
conocido
of
líder
PAHO,
champion,
and a
el
well-known
doctor Matías
champion,
Villatoro
Dr.
del
Matias
Ministerio de
Villatoro
Salud
from the
de El
Ministry
Salvador.
of Health in El Salvador.
Bienvenidos a este panel donde vamos a profundizar lo que es la mejora
Welcome
de
to this panel where we will go in depth on improving quality.
Muy bien, entonces entramos con
Very well.
Esteban, que coordina este panel.
Let's
Esteban
start
Londoño
with
es
Esteban, who
consultor
coordinates this
de la
panel. Esteban
OPS, se
Londoño is a
encarga de
PAHO
la
consultant in
implementación
charge of
del
implementing
programa de mejora de la calidad
the
de heart. Fíjense todo lo
program
que hemos
to
visto.
improve
En el primer
quality in
panel nos
hearts.
dijeron, esto es lo
In
que
the
hay que
first
hacer, pero
panel,
no
they
nos
told us
dijeron
this is
cómo
what we
teníamos
need
que
to
hacer.
do,
Entonces,
but they
sabemos
didn't
que hay que
know
hacerlo, no es
how to do
suficiente.
it. Knowing
Es
what to do is
parte del
not enough.
programa, pero
It's
ahora
just
Esteban
part
nos
of
va
the
a
problem. But
profundizar un
now
poquito
we
con
will
dos
go in
panelistas que
depth
vienen expertos
about
en esta
this
gente
with
que van a hablar ahora no vienen
of
del cine,
panelists
vienen de
who
la concreta,
have
vienen a haber
uh,
hecho
practical
la tarea a
experience.
nivel de su país.
They have
Esteban,
carried
adelante.
out their
Presenta a
tests
los
in their
panelistas
own countries.
y,
Esteban,
y
you
adelante,
introduce
Esteban.
the panelists
Sí,
and
Pedro, muchas
let's
gracias.
start.
Saludos a
Yes, Pedro,
todos.
thank you very
Gracias a
much.
Chile porque estamos
Greetings to
maravillados de la
you all.
recepción
Thank you,
que
Chile.
nos ha
We're
dado el país,
marveled
la
with
OPS,
their
el ministerio.
reception, thanks
Bueno,
to
ya,
PAHO
Pedro,
and
como tú dices,
their
demostramos que
ministry.
tenemos un
Pedro, as you
problema
said,
que
um,
insistimos, es
we
un
have a
problema muy
problem,
grande y no es
and this is
solo
a
un
very
problema
big
clínico.
problem. It's
Este problema,
not
como
only a
nuestro
clinical
profesor Don
problem,
Dupetti, afecta
as
a muchas
Professor
personas.
Dupetti
Esto
mentioned,
va a
it
afectar por
affects so
esta
many
sinergia de enfermedades
people
cardiovasculares,
due
renal
to
y
this
metabólicas.
synergy
Y
of
queremos insistir, es un problema de salud pública.
CKM,
Entonces,
a
¿cómo
public health
abordamos un problema
problem,
de salud
actually.
pública con una
How
visión
can we
internacional?
deal with
Entonces,
a
queremos
public
insistir en eso.
health
HEARTS no es solo
problem
un
with a
programa que aporte las
population
mejores herramientas
or
clínicas
demographic
basadas
view?
en la
It's
mejor
not
evidencia
only
disponible.
having the
HEARTS
best
también
clinical
es un programa
tools
que
based
aporta
on the
las
best
mejores
evidence
herramientas
possible,
de
but also
gestión,
the
pero
best
no las mejores herramientas de
management
gestión
tools.
paralelas a los sistemas, sino las
But they
mejores
are not
herramientas de gestión
parallel
para
to our
contribuir
systems.
al
They are
fortalecimiento de
the
los
best
sistemas de
to
salud
contribute
con enfoque en la atención
strengthening
primaria.
to
Entonces, Pedro, algo que tú
strengthening
repites mucho, pero que
healthcare
queremos
systems
dejar aquí
um,
sentado para iniciar esta
focused
hora de
on primary
reflexión
health
es
care.
HEARTS constituye un
So
programa de
HEARTS is
mejoramiento de
a
la calidad
program for improving
para la atención primaria de
quality
salud.
for
Con
primary
esto
health
decimos que
care.
contribuimos al mejoramiento de la calidad
In
para las
this
enfermedades
way, we
cardiovasculares, renales y
contribute
metabólicas,
with
pero también para todas
improving
las
the
cosas que se atienden
quality
en la
of
atención primaria
care
de
for
salud. Entonces,
CKM,
tengo el placer de
right?
presentar
So
primero
I have
a
the
Marcela
pleasure
Rivera,
to introduce
del Ministerio de
Marcela
Salud de Chile, que
Rivera
es líder
from the
de la
Ministry of Health
implementación de
in Chile.
HEARTS
She
como
is the
líder
leader of
nacional también
HEART's
de la atención primaria
implementation.
en
She's
salud.
also
Tenemos
a
a la doctora
national
Vania
leader
Batista,
for
que ha sido
primary
líder de
health
la
care,
implementación de HEARTS en
Tania
República
Batista,
Dominicana.
who has
Y
been the
tenemos al
leader for
doctor Matías
implementing HEARTS
Villatoro,
in
que ha
Dominican
sido
Republic,
líder y es
and Dr.
líder en la
Matias
implementación de
Villatoro,
HEARTS en El
who
Salvador.
is
¿Qué
a
características
leader
común
for
tienen los
HEARTS in El
tres?
Salvador.
Que
What
son
common characteristics do
líderes de
they
países
have?
campeones
They
de
are
HEARTS,
leaders
que están
of
en diferentes
champion
grados de desarrollo
countries
de
for
acuerdo a sus
hearts. They are at
condiciones, pero
different
que han contribuido a
uh,
salvar
development
miles
degrees,
de
but they
vidas,
have
¿cierto?
contributed
Quizás
to
podríamos
save
decir inclusive
thousands of
millones,
lives.
potencialmente millones
I
de
could
vidas
say
a
perhaps
través de la
potentially
implementación de HEARTS en
millions
la
of
región.
lives through the
Entonces, Pedro y colega,
implementation
vamos a guiar
of
esta
hearts in the
conversación a través de
Americas.
tres preguntas para
So we'll
ilustrar
guide this
cómo
conversation
cuando
to
ya
the
vamos a
three
adoptar
questions to
una cantidad de
illustrate
herramientas clínicas que son
how
las que ha
we're
presentado
going to
el
adopt a
profesor doctor
number of
Daniel y el
clinical
representado
tools,
Andrés,
those
esas
presented
herramientas
by
clínicas van a ser
our
más exigente el
preceding
proceso de calidad.
lecturers.
Entonces
And
necesitamos
these
sistemas
clinical
de salud
tools will make the quality process more solid and integrated. But there are some challenges. before the challenge of Hearts 2.0, we'll have to have primary health care and establishments with a better quality. You know, the Chileans are very honest. We have reflected with Chile that has really an enviable infrastructure, and they have an investment on health and GDP of more than 9%. The first question is, what is this characteristic Hearts has in the Americas? We say that Hearts is a continuous program for improving quality and supporting healthcare systems. But in practice, what is the main aspect that makes a part its program to improve the quality of primary healthcare? Thank you for the invitation. I think there are several aspects. It's not a single one. First of all, it simplifies something that has always been complex. We have, with Hearts, we have easy tools, easy to apply. If I invest only 20% to invest 80% of benefits, in Pareto, as you know, is an envy for all. If I invest 20 pesos and I get 80 pesos as earning, everyone will invest in that. And Hart gives us that return on investment in terms of controlling people so they decrease their likelihood of being sick. So we work with universities, and that helps us to train new students in health professions, something that is very complex. And hypertension, as it has been said, the hypertension class is, let's say, very simple. But what is complex, no one wants to do. So Hearts makes it easy, and we get better results by having that. And quality can be measured in many ways, but we need to measure it in terms of how much pain we can prevent. How many people how many people have less damage? I wouldn't have a CKM or a cardiovascular disease or a brain vascular disease. If I have hypertension, that's a first risk, and I can control it in several ways. In Chile, the people look for the miracle pill. Hearts gives them this. They say, if you take this standardized treatment, you'll have 80% of good results. And this is based on figures. We like to know about outcomes, right? And we get information from database that shows that this reduced cardiovascular disease by 42% and a stroke 80%. It's a miracle pill. It's cheap, and we don't use it. When we don't have the miracle pill, we request for it, and that's in Hearts. We obtain good results with Hearts. I don't know why we don't use Hearts. Thank you very much, Marcela. So Hearts gives a great return on investment, and we have the best available evidence, so it's the best quality standard for all. And the other thing is mentioned by Mr. Pinheiro, with that implementation, you have lots of guidelines with many pages, but we need to have one clinical guideline that simplifies the life to healthcare personnel and save lives. Tania Batista, I greet you. Dominican Republic has been a political support for Hearts. It became a presidential program, a flag program for the country. I mean, an emblematic program for the country. How can you tell us about the aspects that have contributed to improve primary health in your country? Thank you very much. First of all, Something I always say, the fact that I'm speaking before you today is because behind me there's a whole team, right? So first of all, Hearts gets into our country and we immediately understand we need to work as a team. That's the first pillar. We like it the most because it allows the sequence of monitoring, coverage, control. In our country, we have the management team made up by the Ministry of Public Health and National Health Service, which is the executing arm of the ministry, and it's permanently supported by PAHO, and other institutions are linked. We have drug scientific societies and academic institutions. Having said this, I exemplify what you want to get in my presentation. Hearts has allowed everyone to understand how the different pillars make it easier to implement care more harmonically. Also, everyone that spoke today is fine-tuned. It's like having an alignment of mind. If we simplify, but based on evidence, a treatment that will be the foundation for all cardiovascular diseases is one of the biggest milestones we are having, because if hypertension is not treated in time, it's not standardized. If we don't use a protocol and it's used according to custom, perhaps this is why so many millions of people need this kind of intervention. This was understood in the Dominican Republic, this strategic view at central level that is replicated all over the country, because we have health regions in the country. When we saw that there was this good practice, we applied it in our 10 regions, replicating exactly the same process. A team that starts implementing it locally, that makes their lives easier. And centrally, we keep this as governance. Another point you mentioned is that Dominican Republic reached a point in which it was also politically understood and at a very high level. Our Minister of Health, with so many years seeing cardiovascular patients, because he is a cardiologist, understood the need for primary health care to be strengthened. And Hearts, with all its pillars, does so, not only from the point of view of care itself, but also from the point of view of management, as you said. And finally, the good thing is that Hearts has gradually the change it achieved is very rapid, but it's subtle, because we try to harmonize the entire system. We start with some soft indicators, and that allowed teams at local level to feel that they were reaching low-hanging fruits. And then little by little, Hearts became stronger. In the end, we want coverage and control results to start showing that all this Hearts has aimed at is really attained. I think that's the simplest way in which I can explain what happened in Dominican Republic, and you can see it today. I love there are people connecting from the remotest places in Dominican Republic. So you see that it's not at the top, it's the local level. They're talking in the chat, they are saying how well they feel and how well they have understood all this. And this has happened starting with medicine students to, and that was part of what I was going to say, to the President of the Republic. Thank you very much. You have highlighted, I'd like to highlight several aspects of your intervention, which are very important. First of all, we need strategic direction from the health care institutes. Hearts is a transforming factor if we use it that way. We need to reach the top also. We have marvelous support by the Minister of Dominican Republic and even the President, which has led this to take it to the operational level. So the operational teams in your countries have become empowered and execute hearts. I'll ask Matias, who is a leader with his team in El Salvador, to talk about this. And El Salvador is that champion of hearts. They implement almost all aspects of the program. So, Matias, the same question for you. What is the essential element that you would highlight in El Salvador's experience? What has made the difference for you? How has Hearts become a catalyzer of improving quality in primary health care? Good morning, cordial greetings from El Salvador. Thank you very much for your invitation. I'll represent our team. This is not built individually. I'd like not to repeat, but a principle is that we need to take into account the quality principles, and that means being efficient. Heart structure seeks efficiency, and we want it to be safe, person-focused, timely, and equitable. That's what quality implementation seeks, and these are values we see in the heart strategy in El Salvador. It's very well based on the 8 triggering elements, and that's the roadmap, the structure indicators, process and results, and we have well-defined targets with specific standards. Each one of these indicators allows us to assess ourselves and or make a self-assessment, and this is what will tell us where we want to go and allows us to identify how much progress we've made in each one of our healthcare establishments. Hearts is implemented in 100% of healthcare centers in El Salvador, primary healthcare, hospitals, and always valuing these important quality points. We have been talking about a number of aspects, acceptability, for example. Not all professionals accept that. It's important to ask our people, do you accept this program? If you don't accept it, why? So we can do advocacy for the program. Also, installed capacity. Do we have the installed capacity to implement it? And if not, how? What do we need to do to achieve that? So these are important issues to assess. Sometimes some interventions don't change the attitude among their personnel, and then we need to do advocacy.
Muy bien,
I would
Matías,
stop there.
muy bien.
Thank you very much,
Y
Matias.
Esteban, ¿por qué tú no
Esteban.
redondeas ahora
why
¿Cuál es
don't
el próximo
you
paso y cuál es la visión
synthesize
que
what
tenemos de
is the
integralidad?
next
Hemos
step
tenido la
and the
experiencia de tres países, ¿verdad?
integrality
De cada uno
view
está
we have? We
remarcando
have
temas que
had
son
the
esenciales para
experience
ellos
of
y
three
cómo hay
countries
una,
with
como, o sea,
essential topics for them
una comunalidad, hay
and
una
how
similitud
there
en el
is
tipo de
a
los enfoques, ¿verdad?
similarity
Ahí
in
tenemos
their
voluntad
approaches.
política,
We have
tenemos un
political
grupo
will,
gestor, tenemos
we
un plan de
have
trabajo, tenemos una meta
management
clara,
groups,
tenemos
working
datos,
plans,
¿verdad? Estos son componentes
clear
esenciales para que
targets,
yo he
data.
terminado una
These are
reunión hace un rato.
essential components. I
El
finished a
director
meeting
de
a
las
while
OPS le está
ago.
dando un
The
apoyo tremendo a la
PAHO
implementación de HEARTS en los
director
Estados Unidos
is
con todos los representantes
supporting
de
the
la OPS en todo el
implementation of
país.
HEARTS in the
¿Sí?
United States with
Entonces,
all
algunos
the
de ellos decían, bueno,
PAHO
nosotros estamos haciendo
representatives
un gran
from all the
esfuerzo, pero el
different
problema
countries.
es
And
que ese
some
esfuerzo
said,
todavía no
well,
se ve
we're
en los
making a
datos.
great
El
effort,
HIT
but
más famoso, ustedes
we
saben ya, ¿no?
still
Y yo le
don't
decía, bueno,
see the
mira, el problema es
fruits.
que un
And
programa
I was
sin
saying the
datos
problem is that a
terminamos
program
haciendo otra
without
retórica. ¿Qué podemos
data
hacer?
is
O
just
sea,
rhetoric.
nosotros pudiéramos estar diciendo ahora
We
tenemos
need
33 países
to, we can say
o
we have
Vania pudiera estar
33
diciendo tenemos
countries
República Dominicana con un
or
rate
we
de
have
tenemos tanto,
Dominican
etcétera. Pero
Republic
si
at
no
100%,
tenemos datos no vamos a
etc. But if
ningún
we
sitio.
don't
Los
have
datos
data,
hablan
we
por
go
sí mismos,
nowhere.
¿verdad?
Data
Esteban, entonces,
talk
si tú
by
le dieras
talks by
una
itself.
visión final
So
a
can
dónde
you
vamos
give us a
con
final
HART
view
y la política de calidad de
of
HIT, por
what
favor,
we are
adelante.
pointing at and
Sí,
the
bueno,
heart's
Pedro, le voy a dar
quality
le voy a hacer una
policy?
ronda última muy
Okay,
breve a nuestros
I'll
panelistas para que se vayan
have
Buenísimo,
a
moviendo.
muy bien.
Pero
round for our
entonces, mira,
panelists.
para decir, ya hemos mostrado que ahorita el reto que
And we
tenemos
have
es
shown that the
multimorbilidad,
challenge
¿cierto?
is
Nosotros comenzamos con HEARTS, digamos HEARTS
morbidity. We
1.0 y ahí
start with
teníamos
hearts and now we're going
como
to
puerta de
hearts
entrada la
2.0.
hipertensión arterial,
And the entry
¿cierto?
point is
Ahorita Marcela, Vania
hypertension.
y
Now,
Matías ya estamos
Marcela,
diciendo,
Vania, and
vamos a
Matthias
seguir utilizando
say, well,
hipertensión
we'll
como puerta de
continue
entrada,
using
pero vamos a integrar la
hypertension as the
bioquímica,
entry
digamos,
point,
2.0
but
y
we
herramientas
will
terapéuticas, ¿cierto? Y de gestión para
integrate
atender no
therapeutical
solamente
tools
diabetes,
and
toda la
management tools
intervención
but
renal
to deal with
en la
diabetes
atención
and
primaria en salud.
renal
Entonces,
issues
para
in
rematar,
primary
y
health
les voy a
care,
pedir que
right?
seamos muy breves,
So,
queridos panelistas, es
dear
que
panelists,
cómo
let's
ven
be
ustedes las
very brief.
posibilidades de sus
How do you
respectivos sistemas de
see
salud de sus
the
países
possibilities
para que HEARTS
in your own
2.0
countries so
contribuya
that
a el
Hearts
abordaje integrado
2.0
e integral de esta
contributes to
multimortalidad? Entonces,
integrated and
que brevemente nos digan
integral
cuál sería, digamos, como la principal
approach
ventaja
of
antes
this
de aquí cuál
multi-morbidity.
sería el
What is the
principal
main advantage
reto,
you see
querida
in
Marcela.
Hearts
Comencemos con Chile,
2.0
que es nuestro
and the main
anfitrión.
challenge? Let's start with
En
Chile.
Chile lo tenemos implementado en el sentido de
We
que
have implemented
evitar la
it in
fragmentación de
Chile.
las personas.
What
Cuando
we
vemos
want is
personas
to
con
prevent the
desfisiología o que
fragmentation of
acudan con
people. When we
patologías
see the people
y
and their
probablemente vayan a un equipo de
pathologies,
salud,
they
cosas tan relevantes como que el mismo médico hoy día la vea por hipertensión, el día siguiente por diabetes.
they don't
Eso es un problema.
see a doctor for one
Entonces,
thing
HEART
one day
2.0 va a
and a
permitir
doctor
que
for another thing
los
another
equipos
day.
integren a
Hearts
las personas y no las fragmenten.
2.0 will
Entonces,
allow
nosotros
us to
principalmente
integrate
acá
our
en
professionals
caso a la
to
breve
attend
sería
to
haciendo
our
una sola
patients.
palabra,
I think that's the
integralidad, no
advantage,
fragmentar.
integrality, not fragmentation.
Excelente. Muchísimas
Excellent.
gracias. Vamos, Vania,
Thank you
entonces
very
también
much.
con lo mismo,
Vania,
súper
let's
breve,
go
pero
with the
muy
same thing, very
ilustrativo
briefly,
para
but
el
very
abordaje de
illustrative
la
for
pluripatología, de la
approaching
multimorbilidad
the
que HEARTS 2.0 se propone.
pluripathology and the
Eso. ¿Cuál principal
multimorbidity
ventaja le
that
ves tú en
Hearts
el contexto de República
2.0
Dominicana
wants
y
to
cuál es el
deal with.
principal
How
reto
do you
para la
see the
implementación
main
de la
advantages
vida
in
clínica de
Dominican
HEARTS
Republic
bajo
and the main
HEARTS 2.0?
challenge?
Para ejemplificarlo lo más fácil posible, es
To
que República
say it as
Dominicana,
easier as
durante
possible,
septiembre 2024, se
Dominican
convierte en el primer
Republic
país que firma la
was the
alianza por
first
la
country in
APS.
September
Justamente
2024
comprendiendo
that
esta
signed the
imperiosa
alliance
alianza
for
por la APS, ha
the
buscado y entendiendo que
APS,
HEART se ha
which
convertido, se
has
convirtió en nuestro país en
taught
esa punta de lanza
hearts
para
to
poder
be the
unir y comprendiendo
spearhead to
también que la
join
base es
uh,
hipertensión,
other
buscando poder seguir
disciplines,
agregando
understanding
esas
that
otras
the base
enfermedades
is
y adelantando
hypertension.
también,
We have
recordando que
added
República
the other
Dominicana,
diseases,
viendo este
and
efecto de
also
vía clínica,
Dominican
también
Republic saw
haciendo
that
con
this
todas sus
clinical pathway
instituciones a crear la
uh,
vía clínica de
should be
diabetes y
used
también buscando
uh,
ese,
in all its
vamos a decir,
institutions, also
mantener esa
with the
visión preventiva con la
diabetes
parte que es
clinical
renal, pues
pathway
ya está dando
and
los pasos ahora
renal
mismo una
pathway.
mesa técnica
So
permanente
we're
para el
taking
apoyo de
steps
la
towards
ABS
that. We
que
have a
integra
permanent
grandes
working
actores.
table to
Ustedes saben
integrate
perfectamente todos esos actores
such players, and the main output will be launching this year and next year integration with monitoring in chain of what is needed in the entire system without fragmenting, so that the patient is seen as a whole and not as separate diseases. Excellent. So HEARTS 2.0 directly contributes to make integration effective. That's an aspiration we have had in healthcare systems, and we are doing it with the diseases that are the most deadly and morbid. And how does that go in El Salvador? You are an advanced country in HEARTS. What's the main advantage in passing to HEARTS 2.0 and the main challenge? Well, as you just said, we see it in El Salvador as an opportunity. This helps us to integrate services. HEARTS 2.0 is an excellent opportunity. We have been working on this because if we manage hypertension only in terms of cardiovascular diseases, we forget about kidney and other morbidities. So we take cardiovascular risk as the entry point, and we strengthen our healthcare services and our installed capacity to deal with these other diseases in the primary healthcare level to diagnose renal diseases and also obesity, dyslipidemia, etc., because we need to strengthen our diagnosis and management.
We see this as an opportunity. We have important strengths, as we said in the beginning, which is political support and primary healthcare workers. The installed capacity that we have attained until now, that has been very important at national level. The labs are strengthened, and so we don't think this is going to cause problems, but we still see some important challenges, which is especially training human resources, because human resource or personnel doesn't have this integrative approach. So I think that this is an important thing to mention here, because we're going to have to train the health personnel regarding this comprehensive approach. And then the other important topic is continue working with training schools to look at these thematic contents, because hypertension, diabetes, well, that is there in medical schools. When they show us their contents, it's already there. But the thematic content is not what we're requesting. The other challenge that we see is that there are some things that we have to work on at the first level of care, which is the official change of medicine for the first level care, use of statins, high doses, single doses, and the management of medicine that has possible side effects is a challenge that we have to we can change it by training human resources. And that HEARTS 2.0 has important challenges according to what we reviewed, like reducing the intervals for the intensification of treatments. We see that as a challenge because of the installed capacity that we have. But there we have the challenge of working in multidisciplinary teams to distribute the functions. Over. Excellent, Matias. So, dear Pedro, we're going to finish with this panel, and we're going to thank all the panelists and the three countries that participated, and also say this. So let's look in parallel at clinical pathway and management tools. So in parallel, we're going to work with the policy framework for the implementation of quality in HEARTS primary healthcare centers. So there are 11 strategic interventions in the health system, and also a standardized methodology to implement quality improvement. So let's close the panel. And so thanks to all of you. Great, Esteban. And the panelists, excellent. When panelists have so much experience, have so much knowledge on what's happening in their countries. It's very easy for them to look at the essential points. And Matias Villatoro has brought an important topic, as well as Vania, as well as Marcella, which is education. We have to change the focus. Arts has to move to universities. Why? Because people don't, it doesn't get there. So when we talked about, for example, team-based work, and this is something that you mentioned systematically, Esteban, but there's never space in universities for joint training. Instead of saying we're going to talk about um, uh, cardiovascular renal, cardiovascular kidney metabolic syndrome. Well, let's say, for example, let's go into bring the doctors, the nurses, etc. Let's understand physiopathology. Let's understand the instrument that you use. And universities are not doing that. So integration of care and careers is behind. And so this is something which we have to make the difference. So we have been able to create a series of resources in our virtual campus. So El Salvador, Dominican Republic, and Chile have had great success with this. And people can use these resources. But these resources are not used at their full potential by other countries of the region. So I'm going to give the floor to Mariana to thank Esteban, and thanks to Matias, Vania, and Marcela, the panelists, for their excellent presentations. Go ahead, Mariana. Mariana is a hearts consultant in the Americas. She's a doctor, but she does many things. And so, Carolina.
Sigues con Mariana después y hasta el próximo panel. Hasta la próxima presentación.
So,
Carolina, ¿qué tal?
How are you, Carolina?
Now
Mariana is going to show us all the training resources in hearts. And before giving the floor to Mariana, what we said before regarding graduate training is fundamental. So for universities here, what Mariana will show must be part of the requirements. Universidad de la Frontera has it and its resources, and hearts courses should be compulsory on how to take blood pressure, for example, measure blood pressure, for example. And so for all universities connected and for all teachers connected, make these courses an obligation for all pre-graduate students.
También de Heart en las Américas, que nos apoya muchísimo desde donde está, para que muestre todos los recursos educativos y de entrenamiento que
So
son
Mariana
de
is going to show you the training resources, which are excellent quality.
Gracias, Caro, doctor Ordúñez, al panel.
Thank you very
Como
much,
ellos
Carla.
mencionaron y como también
As
ustedes
they
han mencionado
mentioned,
en el
and
chat
as
y
you
durante la
mentioned,
discusión, desde la
the
formación
chat and
privada
discussion,
es
from the
escuela
pre-graduate
darle la
discussion, it is
importancia a la
key
atención primaria y a
to give
HEARTS para
importance
poder
to
lograr hacer este
primary
cambio
care and to hearts to
de
be able to
manera
do
real.
this
Y bueno,
change
sé
in a
que aquí
real
conectados
manner.
están muchos estudiantes, los saludamos mucho, y en ustedes, en sus docentes y en esos tomadores de decisiones, ahí está
And
el
so
cambio.
for
Entonces,
the
gracias por
changes in
estar aquí
teachers and
y
decision makers. So
les
thank you for
queríamos
being
comentar
here.
que hoy hemos hablado mucho de la vía clínica de HEARTS. Como saben, es la herramienta
So we
esencial
talked about
de
the
implementación de la iniciativa,
clinical
pero así como
pathway
la vía
for
clínica
hearts.
tenemos otras
And
herramientas
as that,
esenciales
we have
para la
other
mejora
essential
de
tools
la
for
calidad, y entre
the
ellas
improvement of
algunos
quality.
recursos muy
And
valiosos de entrenamiento
we
y
have very valuable
educación.
training
Nos gustaría
resources and
que los
educational resources,
conociéramos un
and
poco
we would
más
like you to know more about
y que
this.
sepan que todos ellos están disponibles para ustedes. Y lo más importante es que siguen
So
desarrollándose
the
constantemente
important thing is that this is developing constantly in collaboration with experts,
con los países,
collaboration with the countries, and with you.
a unirse a esta comunidad de práctica, y les voy a compartir
So
un
we
poco más de
encourage you to join this practice
recursos que
community,
tenemos.
and
Disculpa
we
porque
want
están
to.
en inglés las diapositivas, ya
So
vimos
sorry
muchos
because
comentarios
these
al respecto.
slides are
Se
in
las
English.
haremos llegar en español, pero bueno, Todos estos recursos están disponibles en
We will
español y en
send you
inglés.
these
Algunos de
resources in
estos
Spanish as
recursos
well. All the
incluyen
resources are available in Spanish and English.
publicaciones, talleres, cursos
They include
virtuales y vamos a
publications,
explorar un poquito más
shops,
estos cursos
virtual
virtuales que
courses,
están
and so let's
disponibles
explore the
para
virtual
todos
courses that
ustedes de
are
manera
available for all
gratuita.
of you
Están 24/7 en el campus virtual de salud pública de la
24/7
UPS.
in the
Están la mayoría
virtual
en modalidad de
campus.
autoaprendizaje. Eso quiere decir que lo pueden tomar a la hora que tengan posibilidad. Están dirigidos
And
principalmente a los
so these are
talleres de atención
directed,
primaria, estudiantes, personal de
this is
farmacia,
directed
enfermería,
to
de medicina, especialistas, entre
pharmacy
todos.
personnel,
Y algo muy
nurses,
importante es que
specialists,
ofrecen
doctors,
todos
it's for everyone.
certificación académica.
And they all
Entonces, vamos a
offer
explorar esto
academic
muy brevemente. Son
certification.
5 cursos los
So
principales
there
que
are
tenemos en
5
Hearts
courses, the
y
main ones that
queremos
we have at
que
Hearts,
conozcan perfectamente.
and we want you to know them perfectly.
El primero de estos cursos
The first
es
one
el
of
de
the first of
apoyo
these
a los
courses
equipos
is
de atención
supporting
primaria para el
primary
uso
healthcare
eficiente de los
teams to
medicamentos
use blood pressure
antihipertensivos y para el
medications
control del riesgo
effectively.
cardiovascular. Este es un curso que se
This
basa en la
is
guía de
a
la
course
OMS para el tratamiento
based on the
farmacológico de la
WHO
hipertensión.
guide for the
Nos da
pharmacological
un
treatment of
panorama muy
hypertension,
amplio de los
and it
medicamentos,
provides
de las
a very
combinaciones que se
large,
recomiendan,
a
su
very good landscape
evidencia,
of
que
the
los
recommended
respalda y las
medications, the
precauciones que se
evidence,
tienen que tomar.
and
Entonces
the
es fundamental
evidence,
para
the
reforzar
precautions that have to be
la práctica
taken.
clínica este curso. El siguiente que
So this is very
tenemos, y
important.
este es un curso facilísimo que lo
And
hacemos
so
en
this is a
media hora,
very
pero
quick
que nos
course that you
ayuda a
can use
recordar
in half an hour,
la
but
técnica
it helps
correcta de la
us
medición de la presión
remember
arterial.
how to
Porque con el tiempo vamos
manage blood pressure
perdiendo
correctly.
esos
Because with
detalles que
time,
hacen que la
we are
medición sea
going to
adecuada.
lose
Y hay algunos
the
estudios,
details
y
that
lo
make
han visto
medication
en
appropriate.
Chile con DIN, que hasta un tercio de las mediciones no se
1/3
realizan
of
correctamente en
measurements are
algunos
not
casos. Y esto puede llevar a errores de
done
diagnóstico y
correctly, and
seguimiento
this can take
importantes.
to
Por lo
diagnosis
que un
errors.
recordatorio cada 6 meses puede ayudarnos bastante a
And
garantizar que una medición
a
sea
follow-up
correcta
can help us make
y
a
lo más
measurement
precisa
correct
posible en todo el equipo que esté tomando
and
la
as
presión
precise
arterial. Entonces,
as
los
and
invitamos a
very
que
precise in all
se
the teams.
certifiquen cada 6 meses en esto.
So you have to be
Otro que
certified in
tenemos
this
por
every 6
último
months. And
es
now a
el
very good
curso
course
de
is the
automedición de la presión arterial. Sobre todo va
self-measurement
dirigido a
course.
pacientes y
This is
cuidadores, pero
aimed
también es
at
muy útil para el equipo
patients and caretakers,
de
but it's
salud
also
para que
very
ustedes
useful
puedan
for the
capacitar a los
health
pacientes y a
team
los
so
cuidadores.
that you
Este es un
can
curso muy
train
breve que incluye videos, una
patients
planilla
and
de Google
caretakers.
para el registro de
It's a
los 5
very quick
días de
course.
la
It
medición de la presión arterial y
includes
una guía para identificar
videos,
cuáles
a
serían los
guide to
dispositivos
identify what are
ideales y
the
clínicamente
um,
validados para la toma
ideal devices, clinical
domiciliaria.
validated for
El
at
cuarto
house
de los cursos
measurement.
es el de
The
impulsores para
fourth
el
one
control de la presión arterial.
is
Este nos explica de manera
the one
detallada
for
toda la evidencia que está detrás de cada uno de los 8 impulsores
blood pressure
para el control de la
pulsers.
hipertensión en
So here
atención
we see
primaria
the evidence
y
that
es
is
un curso
behind
práctico
that. And this is a
con
practical
evidencia
course
detrás
with
de cada uno de los drivers.
evidence that
Y
backs each of the
finalmente, y
drivers.
el corazón de Hearts actualmente, los invitamos a todos a que tomen el curso de mejora continua de la calidad. Este curso está basado
So
en
this
los
course
talleres
is
que se han
based
dado
on
en los
the
diferentes países, como
workshops
el que
that
vimos
have
que se dio
been
ahora
given
en
in the
Chile.
different countries, like the one in
Entonces, si
Chile,
ustedes
for
no han tenido la
example.
oportunidad de
And so if you have
tomarlo
not had the
presencialmente,
possibility of
este es
taking
como
this in
vivirlo, pero de
presence,
manera
this is
virtual.
like
Les
taking
va a
this
ayudar a
virtually.
tener un diagnóstico del desempeño de su equipo de
This is
atención
going to
para el
help you have a
control de hipertensión
diagnosis
y
on the
riesgo
performance
cardiovascular
of
en
your
sus unidades
team
de salud.
regarding
Entonces,
hypertension
muy,
and
muy
cardiovascular risk.
recomendado este
So
curso
it's
para
very
todos los
recommended
que quieran
for
dar una
all
mejor
of those who
atención.
want to provide better
Entonces,
care.
bueno, aquí está el código QR. También pueden entrar a través de la página de Hearts o directamente en el campus virtual de salud pública. Todos estos cursos están disponibles
So these
para
courses are
ustedes.
available
Y como les decía, así como
for
estos
you.
cursos, también este seminario web y tenemos otros seminarios que han
We
sido
also have other
grabados, que se
seminars
suben a la página de Hearts. Están disponibles ahí también para ustedes. Y
They
les
are
mencionábamos
also
en el
available on the
inicio,
Hearts
tenemos
page,
estos talleres presenciales que se han hecho,
but
ya
we have
mencionaron,
these
en 10
in presence
diferentes ocasiones. Un
workshops
curso
that have
coincidir
been
con todos
done on 10 different occasions. It's also a pleasure to see all of the trainings.
Estos cursos, entonces ya van cientos de cursos de mejora de la
And it's
calidad.
been hundreds of courses to improve quality. And I hope that you can replicate this very soon in your teams. Another resource is a very useful tool, which includes a cardiovascular risk calculator that allows to identify several elements very quickly. And there are also other useful calculators. You can also find the clinical guides from several countries so that you can take them into account. And we also have an excellent team for you, which is at the calculator and already be integrated directly in the clinical registry systems. And so you can manage risk in the patient file, and this is through the country offices.
Y finalmente, pero no menos importante, todo el repositorio en línea de más de 120 publicaciones de HEARTS,
and then we have 120 HEARTS publications,
técnicos, material práctico, tienen muchas cosas
practical material, many things in the repository, but this grows every day.
Les tenemos una noticia que ahorita el doctor Ordúñez, Carolina y Esteban les van a comentar acerca de nuevas publicaciones que se van a hacer de HEARTS. Entonces, un gusto tenerlos
it's
aquí.
a pleasure to have you here.
Y aprendiendo en esta comunidad
it's
de
great
práctica,
to have you working and learning in this practice community so that you can share these resources that HEARTS has for you.
Una sorpresa.
Carol, and now Carol and Esteban have a
Mariana.
surprise
Le
for
voy a
us.
dar el
Thank
paso
you
al
very much,
doctor Ordóñez y
Mariana.
a Esteban
I'm going to give the floor to
para
Dr. Ordóñez and
una
Esteban
noticia
for a piece of news.
Es lanzamiento.
This
Nuevo
is a
número
launch.
especial.
Special number.
En la
HEARTS of
revista
the
Panamericana
Americas
de la Salud.
in
Doctor
the
Pedro, ¿quiere
Pan
dar una
American
introducción
Health
para que continúe Esteban?
Voy directamente con Esteban.
magazine
Esteban,
or review.
ya tuvimos el
Esteban, we
suplemento de la revista
had
panamericana
the Pan
de la
American
salud en el año
supplement,
2022.
Pan American Health
Y
supplement in
como yo le he dicho muchas
2022.
veces a
And as I
ustedes,
told you,
hay que publicar los resultados.
we have to publish
Podemos
results.
generar mayor
We have to
atractivo para el
generate
programa si
more
somos capaces de
attractiveness
evaluar las
for
cosas
the
que estamos
program if we
haciendo
are capable of
y
assessing the things that we're
publicarlas en
doing
revistas que
and
se puedan,
publishing the
que estén
interviews.
indexadas, que estén revisadas por pares y
They are
que
indexed
además de
and
eso
peer
se puedan
reviewed. And besides that, we
recuperar y que
can
sean
recover.
y por eso sale el nuevo suplemento de HEART 2.0 de HEART en las Américas, discúlpame, de la revista Panamericana de Salud Pública, haciendo el próximo llamado a los países. Pero voy a dejar a Esteban con los detalles. Adelante, Esteban.
Sí, bueno, Pedro, muchas gracias. Bueno, hoy estamos
Pedro, thank
entonces
you very
haciendo el
much.
anuncio del lanzamiento del número especial de
Now
HEARTS en
we're
las
launching the
Américas en la
special,
revista Panamericana de
we're
Salud
launching the
Pública.
special number of
Entonces
HEARTS in the
estamos haciendo un llamamiento
Americas.
muy cordial
And so
a todos
we
los
are
países a
calling the
que
different
puedan
countries
someter artículos
to submit
científicos
scientific
para la
articles.
evaluación del programa HEARTS. O sea, lo que queremos es promover que en todos los países que están implementando podamos medir la efectividad, cómo HEARTS está cambiando la práctica clínica, cómo está
So we
cambiando
can
la
see how
gestión
HEARTS
en
is
la
changing
atención
clinical
primaria y de esta
practice, how
manera
it's
estamos
changing management
impactando
and primary healthcare, and
positivamente
this
millones
shows
de
how we are
vidas.
impacting
Entonces,
positively
como
millions of
decía
lives.
Pedro, este número especial ya está abierto, pero ahorita
This
nosotros
number
queremos
is
reforzar esta
open,
convocatoria y
and we have to
entonces les
strengthen
voy
this
a decir en qué nos
calling.
vamos a
So
centrar. Entonces,
we're
primer gran
going
mensaje,
to,
nos vamos a
so first
centrar
big message,
en
we're
poder
going to
documentar la
focus on
efectividad, ¿cierto?
documenting
¿Qué está
effectiveness,
cambiando
right?
HEARTS?
What is
Y
changing?
allí
What
los
is HEARTS
invitamos a
changing?
tres
And there we invite
subtemas en ese
you
documentar la
to three
efectividad de la
sub-themes
implementación del programa
to
HEARTS. Uno
document
tiene que ver con la
the
prestación de los
effectiveness of
servicios
the
y el impacto que
HEARTS
está teniendo
project
la atención
or the
primaria. Entonces
program.
aquí hay
First, the impact in
temas muy
primary
interesantes como
healthcare.
por
These
ejemplo
are
cómo
very
está
important
cambiando la
topics, like, for example, how
disponibilidad
it's
y el
changing
uso de medicamentos
availability, the
esenciales,
use of
los
essential
dispositivos de
medications,
diagnóstico, que ustedes saben que promovemos
the
dispositivos
diagnosis
automáticos y validados, la
devices,
adopción de protocolos
the
después
adoption
de la
of
vía clínica del HEARTS, que
protocols
son
or the
los
adoption of
procesos
the
estandarizados.
HEARTS
También son
clinical
bienvenidas las
pathway,
evaluaciones de
standardized
impacto económico.
processes, and
¿Qué tanto
also
HEARTS está
economic
ayudando a ahorrar
impact
recursos, a
assessments.
priorizar esos
How
recursos
much is HEARTS saving?
para mejorar
to improve population care. The other thing that we want to look at is the clinical pathway implementation, how countries are living this. The clinical pathway has a treatment protocol that has the best protocol, but it's also a series of measures that are non-pharmacological, and it's also accompanied by a series of elements. And the third sub-theme is the continuous improvement of quality. So at Hearts, we want to document studies, experiences, analysis. It's not only to change these. So how it, and what is very welcome is the articles that can help us, that can provide data that comes from the monitoring system in the countries. For example, in Chile, you have a great system for data collection, and this. So how can we use this so that it can provide relevant information on the HEARTS implementation and how it's changing quality in primary healthcare? So Pedro y Mariana, we're going to publish the conceptual note. So we have to send it to the ministries so that they can disseminate it, universities as well. We're inviting all universities, research centers, and different schools and different academic players to cooperate with the primary healthcare ministry so that we can help send these articles, and so we can have a better quality in writing and scientific reporting. So we're going to have original articles and brief communications. So in the document that we're going to send, these are the usual norms that we have in the review. So these will be peer-reviewed articles, and they will also have an academic excellence criteria, and they will be focused on topics that we just mentioned. So today we are opening officially, and the first step, colleagues, is to receive a summary, a structured summary of a maximum of 250 words. What does this mean? It has an introduction, it has a methodology, maximum 150 words. We're going to receive, so you have some time to send us your summaries, a maximum of 250 words. So start generating will between academic institutions and primary team. Always going to be responsible for the study that is going to coordinate the others. So form the teams, and we're going to have a selection of these abstracts or summaries, and then we're going to publish on February 10th the summaries that were selected. And between and so you have some time. So on May 25th, you have to send your articles. And there is a huge amount of, so on May 25th, we will have the results on what articles will be published, and the publication will be opened on September 29th, 2026. And so from the time point of view, we have a very good amount of time. So we have to show the good things and motivate our own teams, and we have an ethical mandate to show what is working well so that this can be reproduced by the region of the Americas, but also another region of the world, because they also need to understand what good things we are doing and how they can improve their own primary healthcare systems. And so that would be the invitation, Pedro, to publish HEARTS implementation results through these articles in the Pan American Health magazine. Great, Esteban. We will be sharing this calling through all country offices. We will also publish it in the HEARTS webpage. As I always say, if we do not show what we do through publications, then they will just be forgotten and no one will be able to reproduce that in the future and we will not be able to share what we have learned. And so this is a huge opportunity. We want to thank our panelists, starting by the first group, Professor John Petty, Professor Daniel Piñeiro, Dr. Andrés Rosende. Second group of panelists, we have Esteban Londoño, Vania Batista, Marcela Rivera, Matías Villatoro. Then we have the rest of the colleagues. I also want to thank the transmission, the production, the interpreters, those in charge of the streaming. For those who want to show your cameras, for those who want to open your cameras, please do, so that we can take a family photo. I hope that you enjoyed the webinar. I had an excellent partner here, Carolina Neira. Caro, the final word is yours. Thank you. Family picture, family photo.
Muchísimas gracias a
Thank you very
todos los
much
países que se conectaron.
to all of the countries that
Todos
connected.
los chilenos también que están
Thanks to the
conectados
Chileans
desde
that are connected
las zonas más lejanas. Y ahora vamos a la
in the
foto.
more
Muchísimas
remote
gracias a
areas. And
todos.
now let's have a picture.
Vamos a
Let's have our
organizarnos aquí,
picture
Pedro, para
taken.
sacarnos una foto
Let's
contigo en la
organize
cámara
here,
atrás.
Pedro, to
Así que pone
take a
ahí
picture with
con
you
todos los
behind.
conectados. Muchísimas gracias a todos los
Thank you
panelistas por la
very much to
calidad,
all
por
the
el
panelists
compromiso.
for the quality, for the commitment.
Vamos a sacarnos una foto.
Solo ella en el Zoom toma la foto, pero
Ahí ustedes sacan la foto, no sé si nos vemos en el Zoom
Ahí están nuestros panelistas,
y con
los
los
profesores.
conectados.
Muy bien, muy bien,
Ahí están los conectados, perfecto, una foto.
muy bien. Excelente.
saludando.
Y muchas gracias porque siguen el chat comunicando de dónde son de todos los países: Colombia, Guatemala, Perú, Argentina, San
Sí, ahí
Pablo,
estamos.
Honduras. Caro, desde México, Mariana Rodríguez. Mariana, muy buena
Mariana Rodríguez.
Gracias, Mariana.
Thank
Muy
you,
bien,
Mariana.
muy bien. Bueno,
Matías.
Gilka, que siempre nos apoya en la cuestión administrativa, aquí está, porque
So
para que
everyone
esto salga,
supporting us
hemos
from the
pedido a
administrative
Bolivia,
side,
que
it's
me
great.
ahí de
Está
Chile.
listo.
¿Ya?
No se vaya, no se vaya.
Vengan.
Muy bien, muy bien.
Y bárbaro.
Quieren otro más. ¿Cómo se hace? Así, así. Yo soy así. Sí, ok. Bueno,
Saludos a todos que
Caro,
están conectados. Saludos.
Caro, muchísimas gracias por todos y
Cheers
que
to all.
tengan un
Cheers to
buen fin
everyone
de semana.
connected. Thank you very
Hasta
much.
luego. Hasta luego.